Are you ready to get? I'm waiting for them.
Okay, let's get started. So, I'm Jessica Welter, and I was with Results Physiotherapy in Knoxville, Tennessee, with the Public Health Specialty Clinic. So I'm excited to share this unique case with you. So, my case study is about a patient with dyspareunia and depression. So the purpose, we're going to talk about the definition of dyspareunia. We're going to talk about physical therapy interventions, and then also the impact of psychosocial factors on her prognosis. So dyspareunia is actually defined in several different ways, but essentially it just comes down to painful intercourse. So Fisher defines dyspareunia as pain before, during, or after intercourse. And she actually has a fun fact in here. So 88% of women report painful intercourse. However, this number is likely underestimated because most women don't report their pain and they don't seek medical attention. So Heim discussed dyspareunia. It's not only perpetuated by physical factors, but also psychological factors. So a little bit about my patient. She's 55. She is retired. She worked for a factory. She had a cholecystectomy, which is gallbladder removal, and an appendectomy. She has several comorbidities that we'll discuss on the second slide. And then I have a little star next to grandmother and wife because there's kind of a story behind this. So her husband has 2 grandsons that aren't hers biologically, but he essentially, this is coming from her, that she forced her to adopt them. So there was some tension there. And then also, she doesn't get along with the oldest, who is 8. So he hits her, bites her, doesn't listen to her, doesn't mind her whatsoever. So again, some more stress in her life. So her comorbidities, that she has rheumatoid arthritis, high blood pressure, anemia, depression, migraines, COPD, and she's currently still a smoker. So I have rheumatoid arthritis started because she's been on morphine for 6 years for this. So just keep that in the back of your mind. We'll talk about that a little bit later. So during her history, the first thing that she said to me was, I'm here to save my marriage. So that can mean a lot of different things, right? So we didn't jump into that initially. We wanted to get to know her a little bit. So some of the things that she talked about, she has pain with intercourse. It started about 2 years ago. It's gradual onset. She is relating it to hormonal changes during menopause, which was approximately 4 years ago. She has a 10 out of 10 pain with initial penetration, causing her to tell him to stop. And then what was interesting about her, she actually did her homework. So she kind of knew what to expect coming into this. She brought in a dilator set, and she said that she was able to tolerate the first level with no pain, but she had this pushing out feeling. So a little bit more background on her. She had a gynecology appointment 4 years ago, and the doctor told her to relax, and she kind of freaked out. She was like, what do you mean I'm relaxing? And the doctor told her that she was going to force the speculum open, and she didn't relax. And so essentially she forced the speculum open, causing even more pain, a little bit of trauma. So that's another thing to just kind of keep in the back of your mind when we talk through the interventions. And she also has some urinary leakage. So she reports leakage with cough, laugh, sneeze, and also a full bladder. She has this approximately 3 times during the week, and it only happens at night. And it's enough to wet her underwear. She also said, when we asked her about some dietary things, she only drinks Mountain Dew. She doesn't drink any water. Not sure why, but we had to talk about that. Tried to get her to introduce some water into her diet. So for the objective measures, what we used was the pelvic floor distress inventory. So rehabmeasures.org talks about the lower the score here, the higher the functioning. So really, she wasn't that all disabled, if you will. But the question that made this number was that she had extreme difficulty with sexual activities. It's very broad. So, and then her fear avoidance was an 8 out of 24, which again isn't terrible, but we needed to essentially separate. Are you having fear of just intercourse, or is it physical activity in general, so exercise? Because she has COPD, she's got several different comorbidities. So she essentially said, obviously, terrified to have intercourse, but she did say that she was fearful to have or to participate in any sort of exercise because of her COPD. So I talked to her about that. I talked to her about using the board scale, and that was something that she was considering, but we'll see. So onto the objective measures. So she did have some decreased range of motion and pain with her lumbar screen. So we kind of put this on the back burner. You can have lumbar dysfunction that contributes to pelvic pain, but and you'll see on the next slide, we were able to reproduce all of her symptoms with the internal exam. So we used the Laycock manual muscle test. So P stands for power, and that's essentially the stress or the strength, excuse me. So she was a 2 out of 5, so she was pretty weak with paradoxical contractions. So paradoxical contractions, when I asked her to contract, she relaxed, and when I asked her to relax, she contracted. Now that's kind of putting it black and white. It wasn't like that. It was very spastic and uncoordinated. So because of the hypertonicity that we found in the internal exam, the endurance, repetitions, and quick flips, which are the rest of those, were not tested. So severe hypertonicity of bilateral bulbocavernosus, pubococcygis, and puborectalis, along with incoordination, and then her pain was a 10 out of 10. So this was actually something that, I didn't really ask her about this just yet, but she was able to use the first level of her dilator, which was much bigger than my finger. So she was able to use that, but had pain when I did her exam. So, was it a little bit, she was able to control the use of the dilator versus not being able to control what I was doing? Maybe that played into it a little bit. So here's the lovely high-gut model that we all have come to love over the years, right? So her health conditions we discussed earlier. So I really want to focus here on the impairment. So her primary concern was her pain. So because it was listed as a 10 out of 10, my primary impairment for her was pain. However, we found hypertonicity, decreased strength, decreased range of motion, incoordination, and then paradoxical contractions. So my hope was if we could affect these, we would influence her pain in a positive way. So her activities and participation, she wants to get back to having intercourse, and she wants and needs to have a pelvic exam. So environment, we really didn't go much into that. That's your doctor's office. Creative. Personal factors, she had fluctuating motivation. So she would come in some days, she would have her makeup done, she would be happy, and then the next day it was just, she had a bad day. So she did have decreased spousal support. This was also very interesting. He did not understand why he couldn't do things to her because we were doing things to her. He didn't understand that there was controlled environment there. So I asked her, I said, bring him in, we'll educate him, we'll tell him what's going on. But she wasn't on board with that. So she is still smoking, and then she's also the primary caregiver of the 2 kids. So we diagnosed her with dyspareunia and mixed urinary incontinence. So our main focus was dyspareunia. And based off of my experience and also the literature, we do know that some of the interventions that we use for dyspareunia can carry over and have some influence on incontinence. And then her prognosis, this was interesting. So at first, based off of her research and her compliance and her motivation, she brought in her dilator so that we didn't have to tell her to go get one. We thought her prognosis was going to be pretty good. But as we got to know her and we realized that these psychosocial factors were contributing so much, we put her prognosis as in to return to intercourse as fair. So this is a study by Kimberly Fisher, and I actually use some of the stuff that she says quite a bit in the presentation. So this is a case study, and she had a patient that was 30 years old with levator ani muscle overactivity and dyspareunia for 1 year. So this I put right here because I kind of wanted to support why we diagnosed her with dyspareunia. So she talks about musculoskeletal dysfunction, specifically muscle pain, and hypertonicity of the levator ani muscles is another cause of dyspareunia. So this study by Nombre, he discusses the emotional and cognitive factors such as religion, low self-esteem, body image issues, traumatic experiences, anxiety, and fear responses are among the most frequently presented with painful intercourse. So all of these factors can also contribute to some of the depression that she's having too. So, any questions? I wasn't sure if that was a problem before or not, so I just Okay. So during the evaluation, we noted that the bulbocavernosus, the pubococcygeus, and the puborectalis were the main muscles that were affected. So the bulbocavernosus, I always describe this muscle to my patients as a gatekeeper muscle because it surrounds the introitus and it acts as a sphincter to reduce the lumen of the vagina. It also acts on the urethra, which could be contributing to some of her incontinence that she's having. The pubococcygeus functions as a voluntary sphincter to the anal canal, and then the puborectalis pulls the anorectal junction forward. So she wasn't having any valve dysfunction, but we do know that this can contribute to pelvic pain. So her goals for physical therapy were pain-free intercourse and pain-free vaginal exams. Our plan of care consisted of 2 times a week for 12 weeks. So the next few slides will talk about her intervention plan, her home exercise program, and then the outcomes. So what we focused on was pain science education, which is important for most patients, manual therapy, dilator use, pelvic floor and hip stretches, and hip and core strengthening. So Mosley, who is at the forefront of pain science education, he talks about 4 key points of pain. 1, that pain does not provide a measure of the state of the tissue. 2, that the pain is modulated by many factors from across somatic, psychological, and social domains. 3, that the relationship between pain and the state of tissue becomes less predictable as pain persists. And 4, that pain can be conceptualized as a conscious correlation that the tissue is in danger. So this was incorporated into her plan of care because she's been having pain for 2 years. But also, we really wanted to address the psychosocial factors as opposed to tissue injury. So with what she had going on, she could have had tissue injury had she attempted intercourse because it was so guarded, but she hasn't had intercourse in months. So the tissue, there probably was not any tissue damage. So we also wanted to point out the stressors in her life that were contributing to her pain response as well. So for the manual therapy, we use strain, counter strain, sustained stretch, and then sustained pressure to the external pelvic floor. The sustained pressure to the external pelvic floor was only used when she was sore from dilator use or what we did in the previous visit. And then the strain, counter strain, I like this technique a lot. So Long discusses a passive positional technique aimed at relieving musculoskeletal pain and dysfunction through the indirect manual manipulation. So what you do here is you identify a tender point, and then you put the practitioner then positions the patient so that the tissue is shortened. So what we did was we would put pressure on the pubic bone, and so it would gently shorten that tissue. I do have a classmate, Ashley, who does some pelvic floor stuff as well, and she was talking about how her CI they would use where they would move their leg. So that's just another technique that would have been beneficial as well. Oh, and then, so this was actually interesting. When I was doing her internal work, we would get that tissue to relax and really calm down, and we could get it through the full range of motion. But like any good therapist, when you're doing manual work, you get to know your patient, and you talk to them, and you ask them, you develop rapport. And so I would ask her about her kids and her husband and what she does, and as soon as she started talking about her kids and her husband, the muscle would just tighten right back up. And I would ask her, I said, did you feel that? And she had no idea. But how I would kind of describe it is when you carry tension in your shoulders, it's like she was carrying that in her pelvic floor. It's very interesting. So this is the dilators that she brought in. So the one on the right was the first dilator that she was able to tolerate. And then on the bottom is a handle, so it's not that big. So a review by Reesing examined 22 different studies of treatments for dyspareunia. 18 of the studies involved the use of vaginal dilators, but only 3 of these studies used a combination of the vaginal dilators and the pelvic floor muscle control and relaxation. So these studies reported success rates from 66 to 100%, with success defined as pain-free intercourse. However, the limitation here is that these studies also use a combination of sex therapy and couples therapy, and also communication exercises. So I tried this with her. I really tried to get her to be open to the idea of going to talk to someone, whether individually or by herself or with her husband. And she had said that she had tried it before several times, different therapists, and she just was not on board with it, which was a little disappointing because we could only take this treatment so far. So these are some of the exercises I gave her to go home with. So Cozen discussed a case study with a patient diagnosed with interstitial cystitis, dyspareunia, and low back pain. So she had a little bit more going on physically, but the therapeutic exercises that she used, they consisted of stretches that would open the hips. So happy baby, single knee to chest, double knee to chest, modified down dog, a deep squat, and also diaphragmatic breathing. So in this study, she mentioned, or she emphasized the connection between the respiratory function and the pelvic floor function. So we know that the diaphragm and the pelvic floor sit parallel to each other, and they move together. So if we can get them working on the same team, then maybe we can help her. So during the reevaluation, so she discussed that 70% of her pain, or the pushing out feeling, actually was decreased. She still had burning at the introitus with the level 4 dilator, and I put that right there because she could only get about 2 inches of the level 4 dilator inserted before she needed to remove it because of the pain. So she went from severe hypertonicity of the bulbocavernosus to moderate, and then a big jump from a severe hypertonicity of the later intermuscles to slight, which I was very excited about. And then she also increased her strength to a 3, but she continued to still have the paradoxical contractions. So modifications and progression. So this was weeks 5 through 7. I tried a contract relax technique with her, which didn't work because of the paradoxical contraction. So I quickly just said her lesson more. And then I introduced, so back to the low back pain, I wanted to introduce some just grade 1, grade 2 lumbar CPAs. So this actually increased her back pain just within session. And then at the following visit, she reported a significant decrease in pain or no pain at all, which was really exciting. But it had no effect on her pelvic floor. So discussion about the limitations of physical therapy, this became huge within her treatment plan because we were able to normalize her tissue eventually, but then she would come in her next visit and it would be hypertonic again. It wouldn't be as severe as it was, but it would still be there. So we really tried to push her to go talk to someone because that's essentially out of our scope of practice. We can kind of do surface level listening and trying to tell her that, you know, this 8-year-old child whose father is in prison and his mother's a drug addict is having some other issues that you're here to help them with. So, and then we reinforced relaxation techniques, so that diaphragmatic breathing, and then also segmental breathing. And then I asked her, I said, you know, this is also hard when you have an 8-year-old. You can't just leave a situation. But if her husband was present, if she could just remove herself from those stressful situations, take a couple deep breaths and calm down before she has to go back out there and address it, maybe that would help. Then I also mentioned yoga or meditation. So she was really excited about yoga. She had videos somewhere in her basement that she wanted to dig up and try. So that was exciting. And then so with the dilators, she was able to tolerate the level 3 for 20 minutes, which was huge. She was able to add a self-stretch and twisting. So twisting of the dilator will just add some more stress to that tissue. And we also added some blocked practice with the insertion and removal of the level 3. So from there, we progressed to the level 4 dilator, and she had no further pain with that. And that was really important because the level 4 dilator was most similar in size to her husband. So, and then we added biofeedback. So biofeedback is not hugely supported in the literature. It's supported with the use of everything else, which is what we were doing initially. So I introduced this to her, and I was really excited because I wanted her to be able to see where she was. And I thought that maybe having that visual would be something that would be really beneficial for her. So the literature talks about the average resting tone with biofeedback is about 2 or 3, and it varies. So some people it could be a 5, and only pain that's normal. Hers was a 12. So that's just something to keep in mind there. Any questions so far? I'll show you. Okay, so outcomes, and then this is her final visit with me. So I saw her for 7 weeks. She's still being treated right now. But her PFDI decreased from 21% to 13%, which really wasn't clinically significant. The question that we talked about, she went from extreme difficulty with sexual activities to quite a bit of difficulty with sexual activities. So this is part of one of my limitations, but with this outcome, or the outcome measure that we use here, it really didn't track her progress. She was making huge progress, but can you have intercourse is a yes or no question. It's really no in between. Her fear avoidance didn't change, and then she was able to tolerate the level 4 dilator, so she was able to insert this fully for 20 minutes. The burning sensation lasted for less than 2 minutes, and she was able to apply the self-stretch with no pain. The pushing out feeling was gone, and then the pain with the insertion of a single digit was gone. She still presented with the paradoxical contractions, and then her average resting tone decreased from a 12, and it stayed consistently between a 2.6 and a 3.4. And then my biggest win was the tone of her bulbocavernosus was trace. It was there, I could barely even feel any increase in tone, and that was very exciting. And then also, she didn't have any reports of urinary incontinence, so that was very exciting. So some of the limitations, obviously the psychosocial factors and how they were affecting her tissue, and then also her unwillingness to adjust these factors was also something that was just kind of a downfall and a little bit disappointing, because I think she would have done really great had she been open to this. And then, like I said, the outcome measures, I wish that I had used something that would better track her progress, because the tissues, they were normalizing, and she was feeling a little bit better. So, and then also the intra-tester assessment, my CI did the initial evaluation, and then I took over the treatment, so there was any differences there. And then back to the morphine. Anyway, so I found a study, and 21 of 23 patients reported a significant decrease in pain after a detoxification of opioids. So we know that morphine is an opioid, and then graph A talks about all but 2 patients reported a significant decrease in pain, and then graph B, no matter what the detox regimen was when they were grouped together, there was a decrease in pain. So I'm not an MD, I don't know why he had her on that, but that's something, one of my limitations for myself was maybe I could have called her doctor and talked to him about that. So just to summarize everything, so her progress was not linear, and much like most patients, it's not linear, but hers, especially with the psychosocial factors that were contributing, and also her comorbidities. So I reinforced the relaxation techniques with her because they really worked. She really liked them. She would come in feeling relaxed and ready to go. We had a good time. And then I also forced her to address her stressors in her life. She had no idea how they were affecting her. So maybe accepting those and addressing them would help her. So what next? So since I'm not working with her anymore, what would I do? In terms of interventions, I would activate her transverse abdominis, because that's part of the pelvic floor, or part of the canister that we talk about. So pelvic floor, your transverse abdominis, your multifidi, and then your diaphragm. And then also hip strengthening. So if we can get the paradoxical contractions under control, the next thing would be to strengthen and get some endurance into those muscles, as well as some coordination. So I found this quote online, and I don't know about any of the other third years in the room, but I often felt like this a lot. Even when you fall on your face, you're still moving forward. That's something I had to remind myself. I took a lot of this stuff home with me, and you want these patients to get better. It's such an intimate area. So I talked a little bit about some of the things I would have done differently. One of the things is I would print out a brochure or find a brochure and give it to her in terms of seeking a mental health professional, because talking about it only goes so far. She's at home, she's thinking about it, she sees it on the kitchen table, and maybe she would be a little more motivated to give them a call. And then obviously using some more outcome measures that would better track the psychosocial contributors. And then I also found a depression scale. It's called the Hamilton Depression Rating Scale, and this rates the severity of depression in patients who have already been diagnosed with depression. So this would have been really great, just so we could kind of see where she is with us as we move through her interventions. And the higher the score here, the more severe depression there is. So that would have been nice to have as well. And then possibly, maybe we could have activated the transverse abdominis earlier just to coordinate the pelvic floor. So the transverse abdominis and the pelvic floor, they're like best friends. They go everywhere together. So when one contracts, the other contracts. But what we do like to try to do is isolate them, especially early on in the treatment. So if we could have done that, maybe that would have had an effect. But my clinical reasoning for not doing that was because they do essentially contract together. So those are some of the things that were done different. Any questions?
So you said that you would like to use a different outcome measure. What outcome measure would you like?
So I found the study by
Can you repeat the question?
What outcome measure would you like to use?
The outcome measure to use, just to be more specific, with ones that I was talking about. Gross. Oh, that's so let me find this really quickly. Somewhere. He used like 5 different ones, and they're very long, so I don't really know the names.
So what kinds of things would they have in them? I guess maybe let's narrow it down to that.
So probably just addressing some of the psychosocial factors rather than just the physical part of it. So the PFDI just talked about can you participate in sexual activities or not? And like I said, that was just like a yes or no question. So I'd have to look into that and see what types of questions that they would be talking about.
So like a ranking scale on how hard
Yeah.
is it or something like that.
Mhm. Yeah. Any other questions?
Another question. So did you all use any motivational interviewing? Any that, are you familiar with it?
I'm not familiar with that, but she would come in and she would be excited about getting started. She was very motivated, but when she was having a bad day, she would come in and say, I'm gonna get better, this is not gonna work. But then other days she would be very excited about it. So it was just up and down, it was very all over the place. So
Well, motivational interviewing is not more about how motivated patients, but it's more about creating behavior change.
okay.
And it is a psychological psychotherapy kind of thing. A lot of people like pain science too, so it's just something to think about if you're gonna pursue women's health in particular with a lot of psychosocial intervention. And it looks on it and stuff like that, but basically it looks at where they are in their behavior change. So there is a behavior change theory, which makes sense. And so figuring out where that person is and then asking the right questions so that the patient actually starts making some decisions about what behavior change they can do. And so it's used a lot with, sort of actually being used with people who were addicted to drugs and alcohol. And so it's been around for a long, long time, but that might be something to look at as you progress forward. Because telling somebody and educating them how good they are does not create change.
Right.
If you think about any bad habit that you have, you might know all there is about it. It's just like smoking. Somebody that's a smoker, most of those folks know all there is, know that they can get COPD. She has it. They know that they can get lung cancer. They know all the bad stuff about it. And so there's ways to start helping them implement change, and they make that kind of
That would have been probably very beneficial.
probably very beneficial. I mean, as we were talking about this, I was like, hey, we have a great strategy here that might have at least been got her started. It would not, she probably still wouldn't be going, running up and calling a therapist, but she may be thinking about doing some things differently.
Yeah.
And so it's a skill. I'm still not good at it, but it's something I'm practicing a lot. And when you do use it, it really is very effective.
So I know many of us in here have upcoming public health clinicals,
Mhm.
and I'm just wondering, because she seems a little bit complex, how you figured out where to start with her as a student.
So obviously you have your CI who you can rely heavily on. My CI, because I had a public health internship in the course, she was kind of just like, go. So it was kind of scary for me, but it was great. But she does what Dr. Smith does and just says why. So that took some getting used to. But just know that you always have them and you always have research. So if you don't know what to do right then and there, rely on your CI and then go look it up. With this patient, this was actually my very first day when I switched over. And so I think I was sitting there just watching and I was just like, she'll be a good case study. But so I didn't really make decisions at first, but when we moved through her plan of care and her interventions, that's when I started making decisions. And it comes together, and you'll do the research and the course, you're taking the course, so that'll help a lot too. So,
Was your patient able to have successful intercourse?
No. Unfortunately not. I do think that she would be able to tolerate a pelvic exam, but so this kind of goes back to the psychosocial factors. She said that they were looking towards a divorce. So I don't think intercourse is not just strictly physical. There's the arousal part of it. And she didn't have that. And so I don't think that it's something that she wants to do anymore. So she had this shift in mindset there. So
For the depression side, did you guys do any outcome measures to see if she had any anxiety, depression? Or was
No,
she
so that's what I talked about with the limitations, is I wanted to use that scale because you can use it when they've already been diagnosed, which would be nice to just kind of see like where they are with our treatment. If it gets better, if it's getting worse.
I just want to bring up a point. The progression scale, they're really not our outcome measures, they're really our screening tools. Because if we find out somebody is depressed, that's not an issue of practice, so we do refer out, but it can impact what you do with that. But just keep that in mind. I hear this a lot. This program that we use this as an outcome measure. It's not really our outcome measure, but it's a screen. And it's something we can figure out about pulse.
Great. Is that it?